Anyway, thank you very much, especially to you, Michael, for giving us this overview. As Michael explained, this is a new venture for many of us. It certainly is for me. I'm quite used to the opposite process towards drug discovery, and that is that you do some basic research in a lab, you see some promise in a respected animal model, and then you try to find ways to move this into human clinical practice. What we're dealing with here is the inverse of that. A group of people who are extremely well trained, have a different perspective on the development of medicine as compared to our approach. And yet I think that we're going to see that this approach to discovery is as valid as the one that we use normally. I think an important point to mention here is the fact that this is a collaboration not with a herbal medicine expert, but somebody who is truly one of the gifted phytochemists in the world. Vietnam is fortunate to have developed a National Academy of Sciences. And the premier institute amongst their many National Academy of Science institutes is the Institute for Medicinal Chemistry. And Dr. Sung is the head of that institute. And so when he heard about this development by the herbal specialist, Dr. Dan, his first step was to start to investigate the ingredients. And then originally this was actually a liquid form that was consumed orally. And so in collaboration with his colleagues in Germany, they identified the most promising of the various candidate drugs that Dr. Dan had identified personally, and then began a process of purification, standardized extraction and mixing, the introduction of good laboratory practices, good manufacturing practices, so that they came up with something which is a powdered material pictured here that can be given with confidence to humans because it's non-toxic. They did the appropriate toxicology. There is a history of off-label use of this compound in Vietnam. It's not doing any harm. It's now standardized, and it can be used in clinical trials. So when Michael and I went there 2 years ago and saw firsthand the promise that this particular therapy might have, I offered to Dr. Sung to conduct some preclinical experiments that might provide further insights into maybe mechanism of action. Can we show that it's working in the brain? You know, a host of pretty obvious questions from our perspective. And that's what I want to share with you right now. Sorry, wrong computer. So Michael's already outlined the important ingredients in the research agenda. This picture to the right, it was taken from an article that was published in Nature in 2005. I think it was a fairly balanced approach to the fact that these colleagues in Vietnam were trying a different approach to the treatment of opiate withdrawal, and it certainly seemed to merit further investigation. I think the important thing to emphasize is the fact that this clinical trial is nearing completion. The design of the current trial does have, even though it's still tested against a neuroleptic, it's a much better design. So I think that the data will provide some evidence, hopefully, of efficacy. But the real unknown here is that to date, practically, well, nothing is known about the action of this compound on the brain. There has been no preclinical behavioral assessment using standardized psychopharmacological procedures. And so what I want to do in the next few minutes is share with you the experiments we've done over the last 2 years in our lab at UBC, principally in collaboration with my colleague, Dr. Corinne Diaz, who's been responsible for the behavioral pharmacology, and my colleague, Dr. Soyeon On, who's been responsible for the brain neurochemistry. And so the first experiments I'm going to describe employ a procedure that's used in preclinical studies to try to assess whether or not a compound has abuse liability because an animal finds it to be rewarding. And a very simple way of assessing this is to use this apparatus here called a condition place preference box. And it's a very simple apparatus in which a box is divided into two quite distinctive compartments. And an animal can visit either compartment by moving through this, this doorway. And what happens in the experiment is that you randomly assign the animal to one of these two compartments. And on 4 days, you give it a drug that you suspect may have, or you're interested in assessing whether it has abuse liability. And then on the other day, the animal gets the vehicle in the opposite compartment. And these compartments are randomized. The lighting is adjusted so that the animals have an equal preference between the two compartments. Then after 8 days of conditioning, in a non-drug state, you place the animal at this choice point, and then you simply measure the amount of time that the animal chooses to spend in each of these compartments. We began using this procedure in the 1970s, and it's become quite a popular procedure for assessing drug reward. And so if you were to give morphine in this compartment, the animal would spend significantly more time in the compartment in which it had received morphine, cocaine, heroin, tranquilizers. Every drug that a human chooses to self-administer will yield a preference in this apparatus. So we were interested in assessing the effects of Hiantos initially on the known rewarding effects of morphine. And so the next few slides will show the data in a standardized way. What we're measuring is the amount of time in this non-drug state that the animal chooses to spend in the compartment that was associated with morphine as compared to the compartment in which it received the saline vehicle. And every time you see a significant increase in the opiate compartment, morphine compartment relative to saline, that means that we have a significant place preference. What we did in this experiment is give the animal Hiantos in these various doses, 100 milligrams, 250, and 500 milligrams, 30 minutes before we gave the injection of morphine. So we're looking at what happens on the induction, the formation of the association between the rewarding effects of the drug and the distinctive environment. Will Hiantos affect that? Well, it clearly did. At these higher doses, it blocks the ability of morphine to form a conditioned place preference. Interestingly, this is an experiment in which the animal received morphine with just a vehicle, and then on the test for learning, the expression of the morphine place preference, we asked the question of whether Hiantos could block an already established place preference, and clearly it cannot, because you always see the morphine compartment favored over the saline compartment. But this is encouraging. This compound is blocking the rewarding effects of morphine in a place preference. We were also quite concerned that, and again I should add that we haven't been privy to all of the active ingredients in Hiantos because this is a proprietary drug in Vietnam. It's patented in Vietnam. The Vietnamese colleagues are quite understandably concerned about the proprietary rights. Our role in all of this is to help and to facilitate, hopefully, the development of this. So we respect the fact that they haven't disclosed all the active ingredients to date. But one thing that we were quite frankly worried about is whether or not there might be some rewarding property of Hiantos itself and that it might have abuse liability. So we did an experiment, Karine did an experiment in which here we were not sure what we were going to get. Were we going to see place preference or, as it turned out, place aversion? And so if you put Hiantos in one, give Hiantos prior to placing the animal in one distinctive compartment, what happens is that you actually develop a slight aversion to that compartment. So this drug has no abuse liability, at least in terms of this particular measure, which is also encouraging. And then the other experiment that we could do is look at something called a naloxone precipitated aversion. So in the human situation in Vietnam, you have individuals who are voluntarily choosing to withdraw from treatment with heroin. So they're in withdrawal. Then the question is, can we provide evidence that Hiantos in an animal model buffers this withdrawal state? We have it in the human condition, but we wanted to see what it might do in the animal condition. So in this experiment, what happens is that you give, in our case, morphine for 7 days, and then on the 8th day, you give an injection of naloxone, which blocks the opiate receptors and precipitates withdrawal. In this particular experiment, 36 hours later, you gave the animal a choice between the compartment in which it had experienced here, the naloxone precipitated withdrawal, and a compartment that it hadn't visited. And what you see in every instance is that the animal develops an aversion. Sorry, I gave you the wrong one. It's this dark histogram. The animal develops an aversion to the compartment in which it had experienced the naloxone precipitated withdrawal, but on this measure, Hiantos did not blunt that aversive property. However, when we did a more conventional, sorry for the busyness of this slide, but there are standardized measures of looking at physiological withdrawal symptoms in rodents that are precipitated, again, by naloxone or simply by withdrawing the opiate. And what happens is that we see that there's an attenuation. I have a summary slide in a moment, but across many of these standardized symptoms of withdrawal, we find that Hiantos does indeed have a very powerful effect, as shown in this slide, using the Gellert, very standardized withdrawal test, Gellert-Holtzman test, where you summarize all of those values on the last slide. So these are the withdrawal scores in animals not treated with Hiantos, and you can see quite nicely that 100 milligrams and 250 milligrams nicely attenuate the withdrawal symptoms. So again, our behavioral pharmacology is confirming, in this instance, what we knew from the human, but it does set up, as you'll see in a moment, the opportunity to correlate neurochemical experiments with the behavioral experiments to try to get a better insight into how Hiantos might be acting. Now, we heard this morning in the very first talk about the compelling evidence, both long-standing in the animal literature, but I think Marco's work is amongst the best in the world, implicating the neurotransmitter dopamine in many aspects of drug incentive motivation and the impetus to seek drug reward. And so we were anxious to see whether we could look at the effects of Hiantos on the dopamine system. Now, this slide goes back 20 years and reminds us that if we use the in vivo, so for freely moving animal, unanesthetized, if you put a small dialysis probe into that animal's brain and you put it into the nucleus accumbens, which is where Marco was looking at his PET signals most of the time, and then you look at what happens when you give an injection, in this case of morphine, what you see is a significant increase in dopamine in the nucleus accumbens in response, in this case, to 20 milligrams per kilogram of morphine IP. And then on this graph, it's showing what happens when you give naloxone, and you can get a decrease in the signal in animals treated repeatedly with opiates and see a neurochemical correlate of withdrawal. So what we did, what Soyeon did with Kitty's help, is replicated in our hands what had been reported many times, that if you give an injection of morphine, you get this beautiful increase in dopamine. And what we're showing you here is the comparison of the first response to morphine as compared to the 7th measurement after the animal had been given morphine daily for 7 days. And you can see that these values, whether it's the acute or the semi-chronic, continue to give you this beautiful increase in dopamine. What we also observed was a concomitant increase in the major metabolites of dopamine, DOPAC and HVA, and very little effect on a metabolite of serotonin. So then what we were interested in, I'm just showing you this, I'll get to the point in a moment, but we've also done countless experiments in which we've done similar things by giving an injection of a psychostimulant, in this case, amphetamine. But what I want you to notice is that in the last experiment, dopamine went up, and the metabolites for the opiates also rose. Psychostimulant drugs have a very distinctive signature in which the major compound dopamine is increasing, whereas the metabolites are decreasing, presumably because amphetamine blocks reuptake of dopamine and prevents this intracellular metabolism from taking place. What we see next is, what does Hiantos itself do to brain dopamine? So this has never been done before, obviously. And so what we have is a vehicle condition, and then we have Hiantos. Hiantos is delivered by gavage directly into the animal's stomach. The human patients take it as a pill. And what you see is a very robust increase in dopamine that's produced by Hiantos. Now, we were doing the behavioral experiments and the chemistry together, and when we saw this, we were quite frankly worried that we might be dealing with a drug that had potential abuse liability. And so it's important to remember that the place preference data do not suggest that Hiantos has rewarding properties by itself. The other thing about Hiantos is that it also causes a very sharp and significant increase in DOPAC and HVA, these metabolites of dopamine, and has no effect whatsoever on the serotonin system. So this looks a little bit like an opiate. It certainly doesn't look like a psychostimulant, but I could have put up here an atypical neuroleptic drug, and you'd see exactly the same profile. And we're beginning to suspect that Hiantos might have properties that may be related to antipsychotic drugs. The next experiment that we did was to look at the effect of Hiantos on repeated injections of morphine, and then, as you'll see in the following slide, the effects on naloxone precipitated withdrawal. So again, this is the classical effect that we have now seen many times, where Hiantos caused an increase in dopamine. Interestingly, the very first time we combined Hiantos with morphine, it blunted the effect of morphine alone. This seems to be possibly an acute effect to which tolerance develops, because on the 7th day, that effect is dissipated. And now it's not combining, it's raising the baseline, but there's no occlusion by Hiantos of the morphine-induced increase in dopamine. So they're probably acting by some quite different mechanism. The really interesting experiment that So-Young conducted was this final one, in which we looked at the effects of Hiantos on buffering the effects of naloxone precipitated withdrawal. So I'll draw your attention first to this blue line. These are animals that had been given morphine for 7 days, were then given an injection of naloxone, which precipitated the withdrawal symptoms that I described earlier. And what happened in the case of dopamine was a precipitous and significant and sustained reduction in dopamine. That perhaps is, and people who are experiencing this withdrawal obviously say that it's an aversive state. Perhaps it's the case that naloxone precipitated withdrawal causes a significant reduction in dopamine that's contributing to the aversion that's caused by naloxone precipitated withdrawal. Here's the interesting thing. When you give Hiantos and then you precipitate withdrawal, you completely buffer. You don't prevent the decline that's induced by naloxone, but you completely buffer the significant decrease below baseline. So we're very interested in that particular observation. So what do we have here? We could have found nothing, but we took a compound that had been developed in very good faith, using a different philosophy of drug discovery, and then applied it to a more classical Western European, North American approach to analyzing the effects of drugs on brain and behavior, and saw some very promising effects. We saw that using conditioned place preference, that Hiantos has mild aversive properties, and therefore we would deduce that it's unlikely to have abuse liability on its own. We did see an increase in dopamine efflux, but we would also quickly add that a simple increase in dopamine produced by a drug is not a signature of the abuse liability of the drug. You can get the same signature with a drug that blocks dopamine receptors. But it's very interesting that naloxone is indeed getting into the brain and affecting this important transmitter system. The morphine place preference data, in which when we gave Hiantos with each injection of morphine, we were able to block the development of conditioned place preference, suggests that it might be modulating the reward properties of an opiate drug. And then I think the most interesting of the behavioral data are the effects from the classical assessment of withdrawal, in which we show that Hiantos can indeed attenuate the withdrawal symptoms that are seen in our case with naloxone precipitated withdrawal. And then the microdialysis data provide further insight, again providing the real confirmation that Hiantos is working on the brain. And we were very excited, as I said a moment ago, about the ability to buffer the precipitated loss of dopamine that occurs when you give naloxone to animals that are experienced with morphine. And we think it might be preventing a hypodopaminergic condition, which could be a correlative aversion. And then finally, I guess collectively, the behavioral data and the neuropharmacological data, I think, do provide compelling evidence of a direct action of Hiantos on brain dopamine systems. And of course, these are the very systems that are implicated, I think, very strongly in the neurobiology of addiction. So, starting from scratch, we're very, very encouraged by these data. We're, of course, sharing them with our Vietnamese colleagues, Dr. Song and others, and they're very excited about these data too. And we're continuing to try to understand in even more detail the mechanisms of action of this drug. And I think there's ongoing experiments that I'm not able to describe at this moment, but I can tell you they look very, very encouraging. And I think we really have a good marriage here. This is a good partnership between a Western approach to science and an Asian approach, more traditional, where these two approaches are converging and indicating that this may well be a promising new candidate for the treatment of opiate withdrawal and maybe other forms of psychiatric illness. So thank you very much, and happy to take questions.
Very well. Thank you, Tony. I think what's exciting about this kind of data is, first of all, it underlines the alignment between the traditional medicine and more Western European, as you were mentioning. But it also, I think, helps us think about validation. When we think about addiction, the validation of whether or not we can validate that a treatment is actually addiction-specific in a sense is captured by this kind of data. So, but let's open it up for questions. Sure. If anybody has any questions for Dr. Phillips.
Yes, George. Yeah. You're on. Yeah.
Just one thought about that. Unless something different about this in terms of longer term, it might be of interest to see if that helps people get on naltrexone faster.
Sure.
This extended duration, they're interested in getting people on naltrexone more rapidly because it's expensive to have in the hospital.
Yeah. That's a very good point, George. Thank you. Might add an anecdote here. When Michael and I were in Vietnam, we went and visited one of these small clinics where people could go and receive Hiantos therapy. And through an interpreter, we were chatting with a gentleman who had just finished a 4-day bout of treatment with Hiantos. He had been using heroin for 20 years before he came into this clinic on the weekend, 4 days before we saw him. And again, without any prompting, just sharing his experience. And I don't put any more value in this other than anecdotal evidence. But first of all, he looked completely relaxed. He was not showing any adverse signs of having just gone through a serious bout of heroin withdrawal. He had slept for the first 48 hours or so. This is a highly sedative drug initially, and then had returned. His appetite had returned, and he shared with us the fact that he felt quite good at that moment in time, and he clearly had got through the heroin withdrawal episode with minimal adverse effects. So if that were to be repeated many, many times, and then it would certainly support your suggestion that perhaps it is a promising candidate for easing somebody onto naloxone or maybe buprenorphine or some other form of therapy, so that you could, because what's unknown here is once the person leaves those clinics, you have no idea whether or not they relapse. This clinical trial will assess that, but right now we have no evidence whatsoever. We're going to be looking, obviously, in our animal models whether we can block relapse that's produced by exposure to conditioned stimuli or the drug itself, or other forms of that are highly reliable to induce relapse, but we haven't done that yet. So.
Thank you very much for this presentation. I'm aware of the Encantus project for a long time,
yes,
from Michael, but I've never seen this kind of behavioral pharmacology tests. They're very impressive. I just wonder, about 10 years or 15 years ago, an Italian group was doing detox protocols with gamma hydroxybutyric acid, which is also a strong dopamine releaser, and showing the same clinical signs like sedation and no withdrawal. And they did it successfully. And now we learned the past maybe 8-9 years ago that there's a very high abuse potential in gamma hydroxybutyric acid. So would there be some parallel?
Again, I would be very surprised if that's the case. The individuals in Vietnam that have used this drug are not reporting a craving for the drug or any interest. Hyantos, that little pile of brown dust that you saw there, it's actually quite pleasant. It smells of the cinnamon content in it, and but despite that, there seems to be no interest in obtaining a source of Hyantos. So there's no evidence that it has abuse liability of its own, whereas GBH, of course, is highly abused and is a known problematic drug. So just on those grounds alone, I don't think we're facing the same problem.
Very interesting presentation, Tony. A couple of points I had. One was that did I interpret your data correctly in the sense that when you did place preference versus the true withdrawal signs, that there was a bit of a mismatch?
Yeah, that was that experiment. We failed to block the aversion produced by naloxone precipitated withdrawal when we gave Hyantos prior to the withdrawal. So there is that disconnect there. But and again, we use several doses, so those are the data. When we use the more conventional way of evaluating withdrawal symptoms, which is more based on physiological reflex and psychomotor activity, then we saw clear beneficial effects of Hyantos in buffering the withdrawal symptoms, both at the low dose of 100 milligrams per kilogram and also 250.
Excellent. And the second question I had was in terms of long-term use of Hyantos and probably impact of Hyantos on the craving for drug. Have you tested for craving?
Not yet. We are moving our labs into this building, and it's been a challenge. So hopefully we'll get to that this summer.
Thank you.
Okay, well, we better keep things moving here. Thank you very much.